So good evening, everyone. Welcome to the first ACNS Win Webinar for this year. We're very happy to have everyone joining us today. I think we have quite a fair amount of participants I see joining in this time. It's great to see everyone in the new year. I think everyone is just out to start off the year in a good way. So we start off with our first speaker, Dr. Mizuho Inui. She's a consultant neurosurgeon from Symphony Clinic, Tochigi, Japan. And she will be talking about the medial sphenoid wing meningioma surgeries for beginners. So, are you ready, Prof?
Thank you for your introduction. Let me share my slide. Can you see my slide?
Yes.
So my name is Mizuho Inoue from Utsunomiya, Japan. It's a pleasure of mine to have the opportunity to talk on this webinar today. And I'm afraid that I'm not much of an expert yet. However, I think I hope that you find it interesting to hearing from mid-level female neurosurgeon like me. So I'd like to talk about what I have learned so far. I'm in the 13th year of my career and I aspire to be a skull-based surgeon. So after finishing neurosurgical residency in Japan, I had a skull-based fellowship in the University of Colorado, the US, under the mentorship of Dr. Sami Youssef. And after I came back to Japan, I had skull-based training in the Saitama Medical University under the mentorship of Dr. Soichi Oya. And recently I moved to current working place to start my own practice. While experiencing skull-based training both in the US and in Japan, I found it's very difficult to learn skull-based surgery. The number of the cases is small, and the procedure is too risky and time-consuming to let the trainees do the case. During training period, I watched a lot of cases, but didn't have opportunity to actually do skull-based case by myself. So how can I start skull-based surgery? I think it would be ideal to start with less complicated cases. When I became able to manage non-skull-based meningiomas like this, it's still so far from doing complicated skull-based meningiomas like this. I needed some cases in between these two for the next step, and then I came across this case. This is the first medial sphenoid wing meningioma that I have operated, and I learned so much during preparing and actually operating this case, which I would like to share with you today. Let me start with the overview of the sphenoid wing meningiomas. Sphenoid wing meningiomas are a heterogeneous group of tumors, which usually divided into three groups according to its attachment, which are medial, middle, and lateral sphenoid wing meningiomas. Medial sphenoid wing meningiomas are also called clinodal meningiomas, especially when it's located more medially and involving neurovascular structures. Middle and lateral sphenoid wing meningiomas are often taken together, and these are less complicated tumor not involving medial neurovascular structures. However, it sometimes involves the neurovascular structure in the sylvian fissure. In addition to these two globular tumors, there's another subgroup called the suphenoorbital meningioma, which is on-plaque meningiomas and usually some bony extension and present with proptosis. So let's take a look into the medial sphenoid wing meningiomas. There are different technical challenges according to its location or tumor characteristics, especially the involvement of the medial neurovascular structures including the major artery encasement is the most important factor that determines the surgical difficulties. So in the cases of the complete encasement of the ICA M1 and A1, or in the case of ICA stenosis caused by the tumor, the risk of the ischemic complication is the highest. And in that cases, planned subtotal resection is recommended to avoid ischemic complications. So in addition to major artery encasement, optic apparatus compression or optic canal invasion are important factors that related to the difficulty of the surgical resection. But usually, the more medially tumor extends, the more neurovascular structures is encased. So if I try to start medial sphenoid meningioma surgery, it's better to start with the cases with minimal medial extension, like the upper images. Other factors that affect challenges, technical challenges, includes cavernous sinus involvement and tumor characteristics, including size, consistency, or vascularity. So here's the presentation of my first medial sphenoid ring meningioma. The patient is 67-year-old female, presented with transient motor aphasia. The patient did not have any visual deficits. MRI revealed the left-sided medial sphenoid ring meningioma with maximum diameter of 5.5 centimeters. The tumor attachment was lateral to the optic nerve, and the tumor did not invade the optic canal. CT angiogram showed the ICA displaced medially and M1 stretched and displaced upward, but the tumor did not encase these arteries more than 180 degrees. Based on these findings, I thought this case is not so much complicated. CT angiogram also showed the feeding artery coming from the superior orbital fissure, which is the recurrent meningeal artery. So I started to prepare for this case, and my mentor used to say, copy completely what I do. So I started with searching for the similar cases operated by my mentor. So I picked up these two cases. Both are the medial sphenoid ring meningioma but not extended medially so much. The tumor attachment was lateral to the optic nerve. The reference case 1 looks like the mirror image of the present case, but the tumor main feeder was coming from the ICA inferior trunk. The reference case 2 has a more rostral extension, but the tumor located on the same side, the left, and also the main feeder was coming from the recurrent meningeal artery, as same as the present case. So I watched these videos repeatedly, and when I watched the tumor on the opposite side, I flipped the video so that I could imagine the actual operative field in the present case. Then I wrote down the operative plan and shared it with my mentor. Here I listed the surgical steps of medial sphenoid ring meningioma resection. Extradural procedures include extensive drilling of sphenoid ring, anterior clinoidectomy, and coagulation of feeding arteries. Intradural procedures include only detachment, effective debulking, and dissection from the surrounding brain, which are the basics of meningioma surgeries. What is specific about the tumor of dislocation include dissection from the optic nerve and from the ICA and MCA. For the present case, I plan not to do anterior clinoidectomy based on the tumor location lateral to the optic nerve and the absence of visual deficits. Also, the dissection from the optic nerve seemed unnecessary for this case. From here, I will share what I learned from the two reference cases. For extradural procedures, extensive drilling of sphenoid ring is important, which is usually hyperostotic, and this drilling could obtain large working space for tumor detachment. And also, this drilling facilitates the coagulation of feeders, namely recurrent meningeal artery in the superior orbital fissure, like in my case, and middle meningeal artery. So this is a video of the reference case. The tumors on the right side. The sphenoid ring bone was widely drilled using a cutting burr. And then diamond burr is used to open the superior orbital fissure. There was a small feeders from recurrent meningeal artery, which is coagulated and cut. In this case, anterior clinoidectomy was not done. However, the tumor was detached with minimal brain retraction and without sylvian fissures, so the extradural procedures created enough space for tumor detachment. Here the ICA and the optic nerve identified medial to the tumor attachment. So these images show the sphenoid wing before and after drilling. This triangular space created by drilling facilitates tumor detachment after dural opening. This is another case showing the extradural procedures. The tumors on the left side, and this tumor was fed by the prominent feeder from recurrent meningeal artery, which is evident on the temporal tip dura here. The superior orbital fissure is opened by diamond burr. And for this case, anterior coronoplastis is also drilled. Meningo-orbital band is cut. And now prominent bleeding from the recurrent meningeal artery feeders is encountered, and then coagulated with bipolar forceps. The roof of the optic canal is drilled to reveal the optic sheath, and the tip of the crinoid is drilled and removed. Here's the remaining optic strut is also drilled and removed. In this case, middle meningeal artery was another prominent feeder. In such a case, my mentor liked to cut the superficial layer of the dura parallel to middle meningeal artery. With this maneuver, middle meningeal artery pops up and they become easier to be pinched and coagulated with bipolar forceps. With these extradural procedures, enough space is created and adequate devascularization is done. Recent radiological studies show that 90% of sphenoid-rich or olfactory groove meningioma has feeder from recurrent meningeal arteries, while 60% have feeders from middle meningeal arteries. Therefore, opening superior orbital fissure and coagulating recurrent meningeal artery is an important step for devascularization. For the intradural procedures, I reviewed the dissection technique of the tumor from the surrounding brain, especially effective use of cotton patties and suction. And I learned the dissection technique of the tumor from ICA and MCA. The basic steps here are splitting the tumor above the ICA and M1, and then dissection from the perforators. This video shows the dissection technique of the tumor from surrounding brain. A thick cotton patty is held with a brain retractor, and with a bipolar forceps, tumor capsule is pulled out. At the same time, thin layer of brain tissue together with arachnoid is put back using the suction tip. The tumor is debulked, and the deeper part of the tumor capsule is pulled out. Now suction tip is used to hold the cotton patty to rub the surface of the tumor capsule. Next video shows the dissection technique of the tumor from ICA and MCA. The tumors on the right side and the ICA is followed distally, dividing the tumor above it. And then at the posterior surface of the tumor capsule, M1 is identified and followed proximally. The dorsal aspect of M1 to ICA is fully exposed. And then with more oblique viewing axis, the lateral aspect of the ICA is dissected. 𝑣𝑘𝑜M is identified over the arachnoid layer. And here, the tumor is gradually thinned out using micro scissors to preserve anterior choroidal arteries. Here's another video showing the dissection from ICA and MCA. The tumors on the left side, and for this case, the M2 inferior trunk was first identified at the posterior capsule here and followed proximally to M1 and A1 and ICA. 𝑣𝑘𝑜M and anterior choroidal arteries are identified, and then M1 is followed backward to the MC bifurcation, and then M2 superior trunk, which was tightly adherent to the tumor capsule and dissected sharply using micro scissors. This illustration from Neurosurgical Atlas beautifully illustrates the dissection technique of the tumor from ICA and MCA. Usually, the MCA is identified at the posterior aspect of the tumor capsule and followed proximally. And ICA is identified deep to the tumor attachment and followed distally. The tumor is split above the ICA to M1 into two pieces, and the tumor is mobilized from each side, preserving perforators. So when mobilizing the lateral aspect of the tumor, care should be taken to preserve PCOM and anterior choroidal arteries. And when mobilizing the medial compartment, M1 and A1 perforators should be preserved. Finally, this is the case I have operated. The tumors on the left side. The sphenoid bone is drilled with cutting burr, bone drill, and then a diamond burr to open the superior orbital fissure. The meningoorbital band is cut, and the prominent feeder from recurrent meningeal artery is identified, which is coagulated and cut. Here's one more feeder being coagulated and cut. And after dural opening, the tumor is detached from its attachment to the sphenoid ring dura. The tumor is then dissected from surrounding brain using thick cotton patty and debulked. And the deeper part of the attachment is being detached. The optic nerve and the ICA was identified medial to the tumor attachment. The tumor was also detached from the tentorium, and the temporal part of the tumor is taken out. Here at the posterior wall of the capsule, MC bifurcation is identified, which are tightly adherent to the tumor capsule. Thick arachnoid is cut, and the small feeder from the MCA is coagulated and cut to free the MC bifurcation from the tumor capsule. Tumor is further debulked to follow the M1 proximally. A blade of a bipolar forceps is inserted between the M1 and the tumor to coagulate the tumor and cut it. The arachnoid over the ICA is opened, and the ICA is followed distally. Again, the tumor is split using the bipolar cautery and also micro scissors. Now the tumor is completely split into two pieces, and the lateral compartment is rolled over to reveal PCOM and anterior choroidal arteries. There was minimal adhesion being coagulated and cut, with care taken not to injure anterior choroidal arteries below. The lateral compartment is taken out, and medial compartment was mildly adherent to the medial side of the M1, which was carefully dissected not to injure M1 or A1 perforators. The medial compartment was also taken out. Near total resection was achieved with small pieces of the tumor left in the superior orbital fissure. I managed to complete this case under the mandated supervision, and after surgery, the patient had a transient worsening of aphasia, but later recovered completely. After experiencing this case, I felt that I became ready for more complicated cases. This is my current experiences as an aspiring skull-based surgeon. For beginners, I recommend starting with less complicated cases and copying mentors doing the similar cases. Skull-based fellowships are, even just watching, great opportunities to collect reference cases, which are the best running materials. Thank you.
Okay, thank you so much, Dr. Mizuho. It was a very good presentation. Before I go on further, first, guys, today I will chair for webinar today, Professor Mina. Hi, Mina, sorry. So, Mina Subana is actually a consultant pediatric neurosurgeon from Dr. Hassan Sadikin Hospital, Bandung, Indonesia, and she's sharing the webinar today. So, I'll let you take over, Mina.
Thank you, Sarah. Okay. very wonderful surgery. It's look like an expert doing that is unlike a beginner, Dr. Inoue. It's wonderful surgery and very keen dissection and very small bleeding. I wonder if you how to identify the feeder before you do the surgery itself. Do you is there any DSA, or do you perform embolization to make it a very keen dissection with less minimally bleeding? Do you do any kind of embolization before surgery?
Thank you for your question. Usually, we don't use the DSA before surgery. It's except for the really complicated cases need the preoperative embolization. So we routinely do the CT angiogram instead, and usually it's show the feeding artery very nicely. So as in case I presented.
Yes, I see from your presentation there's a picture of the from you probably reconstruct it from the MRI or CT scan that shows tumors with the feeders. I wonder what is the app you use for reconstruct the from the imaging, or it comes with imaging itself from the radiology, or you use yourself application for doing that?
Thank you. Actually, I don't know the name of the application or the workstation. It's the one that our radiologists use, and they are so good at reconstructing the very useful image for the surgery. So, yeah, I'm really grateful for them, but I cannot answer for your question.
Oh, it's okay. Okay. Probably from discussion we have here. Discussions is Dr. Ahmad Fahmi from Indonesia, from Surabaya.
Okay.
And
Thank you, Dr. Mirna.
Okay, please, Dr. Fahmi.
Thank you, Dr. Mirna. Thank you very much, Dr. Inoue, for the presentation. Is there any lumbal drain that you use before surgery to make good dissection like that? Any lumbal drain before surgery? Using lumbal drain?
Lumbar drain. Oh, so yeah, we usually do not use the lumbar drain for the this procedure. Even we do the extradural crinoidectomy. So yeah, we just not routinely doing that for especially for the supinoid vein meningiomas.
Without lumbal drain, yeah?
Without, yes.
Okay. Yeah, thank you.
Thank you.
I think Ohata Sensei, can you make some comment for her?
Oh, okay. Thank you. Inviting me to the Young Neuroscience Conference. So, due to operation, of course, my comment is, if the hypervascular tumor, I recommend, of course, embolization before the operation. 1 week before the operation, tumor should be embolized. And the timing of the anterior crinoidectomy is matter of discussion. If the tumor is large, and sometimes tumor involves the optic nerve, so epidural exposure of the cranial process sometimes damages the optic nerve. So basic approach to this particular medial spinal ring meningioma is, for me, is subdural approach. So of course, some spinal wing should be resected, and sometimes I perform the 𝑣𝑪𝑵𝑚 approach. But cranial process should be removed after the tumor dissection, after we have a good orientation to the deep-seated structures. And then if some case M1, A1, C1 is involved by tumor, so sometimes if requires, I open the Sylvian fissure to identify the M1 portion and A1 or A1 segment. So anyway, I congratulate that you have got a nice operation. Thank you.
Thank you so much for your instructive comment. I will try that if the next case for next opportunity to do the case. Thank you.
So, Sensei, just I might ask for preoperative embolization that you mentioned about a week before the evacuation of the tumor.
Yes.
So, what is some because someone said just 1 day before, someone said the 3 day before. What is the best timing? Just let us know and why.
Best timing, so I sometimes perform the embolization 1 day before the operation. If the some complication take place, it's very we need another care to the patient. So I recommend 1 week. This is my just protocol. And 2 weeks sometimes 1 week the tumor becomes soft. That is a very important. Tumor has a necrosis and tumor becomes soft. So regardless the location of the meningioma, I recommend to wait 1 week. This is my comment.
Okay. ありがとうございました。
Thank you very much.
Sharon? Please, Mirna.
Thank you very much, Professor Kato and Professor Ohata. Maybe from another discussion, Dr. Mama Dahlia, please. Any?
Good day, everyone. Thank you so much. Dr. Mizuho, nice presentation. Professor Kato and Professor Kenji Ohata, thank you for organizing this wonderful webinar. In our cases, in some of our cases, which I encountered sphenoid wing meningiomas, there is some, usually they are, in case of large sphenoid wing meningiomas, there is no space left in the Sylvian fissure to open the cisterns, and usually they are covering the cistern, and when you do the craniotomy, there is there is some swelling on the brain. And what do you suggest to make the brain lax in these cases? Or what kind of maneuvers can be taken to easily retract the brain tissue? What kind of what's your point? What's your pearls in these cases? In case of large meningiomas.
Thank you for your question. In such a case, you have to try to dissect the Sylvian fissure or try to open the IC cistern to take out some CSF out, but sometimes it could be difficult because of the tumor, and so yeah. So in such a big tumor, like the Dr. Palmi said, placing the lumbar drain before the surgery is one option to get the brain relaxation. I should consider about that.
Okay, maybe.
May I give a comment regarding the spinal drainage? Spinal drainage is very dangerous. I cannot recommend the spinal drainage to the supratentorial region, because if you have a post-operative hemorrhage, and there's a high risk of the tentorial herniation. If in case of petroclival meningioma, of course, we insert the spinal drainage before the operation, because we did perform the tentoriotomy. There's no chance, no risk of the tentorial herniation. So I cannot recommend spinal drainage in the patient with a supratentorial region. This is my comment.
Okay, thank you so much.
I think
Please go ahead.
I think what you can do is the standard procedures. When you're opening the bone, maybe you can give mannitol first, all right? So that when you open the bone, sometimes that helps. Right? Of course, prior to surgery, you can give DEXA, okay, dexamethasone, right? And then remember, you're dealing with the meningiomas, which are actually usually extraaxial. So sometimes being prepared early and knowing what is your direction to this, the better exposure of the tumor will help, because then once you start debulking, you will start to, resolve it. And of
Compressive.
getting the assistance, yeah.
Okay.
Abi?
Abi Shah? Abi?
So basically for large tumors, what we do is we straight attack the base of the tumor. So once you start dissecting from the base and you detach it from your attachment, you will invariably end up in the Sylvian cistern. And then once that opens, immediately everything becomes lax. The second thing is, if you can go medially and open the chiasmatic cistern, that is another helpful maneuver. But if it is a large tumor, don't wait, just attack the tumor, because it's already made enough space for you. It has splayed the brain and the tumor is right in front of you. So just enter into the tumor, and as you start debulking, some cistern will open and you will be able to enter the tumor and relax the brain.
And sometimes it's actually helpful because the tumor will actually sort of come out by itself, and it'll actually help you delineate easier. And then you get the assistance, and then it'll become suddenly, clearer. Okay, so any more questions?
Okay.
Yeah.
Is there any question from, are we taking any question from the participants?
I don't think there are no questions here, so I think we can continue.
Okay. Probably we can continue to our second speaker. Our second speaker will be Dr. Asma Muhammad Afifi for intraventricular tumor excision. Dr. Asma is from Malaysia. She had her undergraduate MBBS from Indonesia, right? From Gajah Mada, and then get her master of in surgery, neurosurgery from University Science Malaysia, USM, 2019, and she right now working in I'm sorry, I didn't notice. And okay, please do your presentation.
Hi, and thank you for everyone. Can you see my screen?
Yes.
Hello?
Yes. But please make it a full screen.
It is okay. Now it has stopped. Please share again.
I think Raja can.
Okay.
Okay.
You
Okay.
have.
Okay, can I start now?
Yes, please.
Okay. Hi everyone. My name is Asma Muhammad Afifi. People call me Asma. I'm a neurosurgeon from Hospital Sultan Aminah Johor Bahru, hospital in Johor, Malaysia, the southern part of Asia continent. So today I'm going to talk about intraventricular tumor, how I do surgery. I haven't gone to any specific skull-based training, but I plan to do so. My mentor was the previous one was Miss Sharon, and also Mr. Azman is my head of department. So today I'm going to talk about the intraventricular tumor, 2 cases if possible with a given time. So for intraventricular tumor, it's a significantly challenging procedure because we have to know definitely the type of the ventricles, then the location, and also the histopathologic features, tumor size, and vascular supply. And for first case, I'm going to talk about is a 40-year-old lady with no medical illness. She had history of MVA in September 2021. According to her, she claimed no forgetfulness and injury during that time. But she came to us a year later in September 2022 because her father claimed that she is unable to concentrate and easily become forgetful. She sometimes stopped in the middle of the road when she was driving and she forgot her destination. After that, she also met with several accidents but doesn't cause her any major injury. She will hit car or object on her left side. The father brought her to hospital because at that time, after 3 months, starting July 2022 to September 2022, she had her memory impairment became severe, and then she had urinary incontinence and unsteady gait, which we believe is hydrocephalus, but she has no history of fever. So on examination in our center, patient is alert but had childish behavior, immediate and recent memory impairment, but her memory intact, remote memory is still intact. No hallucination. MMSE score at that time was 24/30. Her cranial nerve examination revealed that she has a visual acuity still 6/6 bilaterally with left homonymous hemianopia. Motor, sensory, and cerebral examination are intact. So this is the first scan done for her. Showed there's a large solid mixed density lesion over the left right ventricles, which is size of about 6 × 6 × 3 centimeter with mass effect causing midline shift to the left, partially effaced vessel cistern and hydrocephalus. So based on this scan, we proceeded with MRI, showed there's a lesion over the right intraventricular right lateral ventricles, and actually causing dilatation of the right temporal horn, and also mass effect and also ongoing hydrocephalus. So for this patient, because looking at this scan, we believe that this patient has hydrocephalus with tumor. So the first scan, when we plan to do intraventricular tumor in our center, first we have to think about CSF diversion during the surgery temporarily, because we're afraid during the surgery, post-giving mannitol and post-giving DEXA, the brain is still swollen. So at that time, we plan to put external ventricular drainage over the left frontal horn. And on top of that, we also arrange this patient using carbon clamp, because we are planning to do intraoperative CT scan if there is complication or anything that happened to the patient intraoperatively. So our plan for this patient is left frontal EVD, right microscopic parietal occipital craniotomy, because the tumor is really big. We don't think we can do it endoscopically, and tumor excision. So we start with the left frontal EVD, moderate pressure is clear colorless CSF. So this is the patient's position for the craniotomy and tumor excision. We place the patient on supine position, head turn to the left side with right shoulder elevated. The X area is actually the King's point, where we actually introduce and approach the surgery from the King's point, and then we dissected until we achieve into the tumor area. So I'm going to share the video.
Please share again. It went on.
Okay. Okay, so
It's not playing.
so this is the surgery for this patient. So intraoperatively, we identify the tumor, and then we debulk, we de-dress and also devascularize and debulk the tumor. So we started with the center. Bleeding can be controlled, but unfortunately, I think about 30 minutes during the procedure, we noticed that the brain is bulging, and then we further debulk and also we control the bleeding, but the brain is still bulging, so we are not sure what is happening during the procedure. So we stopped at that point, and then we did an intraoperative CT brain. We noticed that the temporal horn is dilated further, and actually like entrapment during the procedure. So after that, we continue with the dissection. And at this time, previously we planned to create the CSF, to get the CSF diversion temporarily from the middle and anterior side. But now we go more to the frontal and lateral side. And after that, we noticed that the brain sunken, and also we can go on with the surgery calmly, and actually compared to the time when the brain was bulging. So same like as the because our impression is meningioma, so we did devascularize, debulk, and also we dissect and de-dress and dissect the tumor until we can get into the until we can see the ventricle and ependymal and also wall. So here we hemostasis the bleeding, and then we debulk, keep on debulking. We use CUSA and also bipolar coagulation. And at the end, at one point when we noticed there is a big vessel coming from the medial posterior side, which is we believe that is a median arterial veins. So we just left the artery, or we just left the vessel there, and then we just keep debulking the tumor until then we just leave the portion of the tumor that is attached to the vessel there. This surgery took us about 8 hours, and post-operatively, we did a CT scan for this patient. We did clamp the EVD for this patient because the EVD is meant for the temporary CSF diversion during the surgery. In this video, actually, I'm showing you some of the technique that we use. We are controlling the bleeders by using bipolar coagulation, and then we remove the tumor, and then we don't think that the vessel is actually the feeders, but we think it's only an passage. So we leave the vessel behind with a part of tumor left behind attached to the vessel. And so towards the end, we're able to secure the hemostasis, and the brain is not bulging as the earlier surgery, and patient is able to extubate after that. So this is the area where is the last attachment we remove, and then we took out the tumor. And okay. Okay, this is the post-op scan for this patient. Shows there's a clot at the tumoral bed, but there is no hydrocephalus, and the EVD on the left side is clamped, and then we challenge EVD for 3 days. And then this is the scan post-EVD clamped, and then we remove the EVD. And the HPE result came back as meningioma grade 1. We follow up the patient post-surgery for 3 months, 6 months, 9 months, and 12 months. Patient is still has left homonymous hemianopia, but it's reducing compared to before with improved MMSE score, no abnormal behavior, independent, and able to go back to work. This is the MRI post-surgery done this year, which is showed there's a residual tumor of 0.5 times 1 cm times 0.5 cm at right temporal, actually trigone region with no hydrocephalus. I would like to share another case, which is, I think, is more complicated for us compared to the previous case. This is a 23-year-old lady which presented with frequent forgetfulness for about 6 months, and keep asking similar questions to the mother. She also had biparietal headache for 2 weeks, but she also claimed blurring of vision, but claim worsened, no history of trauma, and she is working as a volunteer at one of the orphanage in her center. Her examination was, she was alert and conscious with MMSE 24/30, impact in orientation, attention, recall, and recent memory. So we did a scan for her, showed there's a midline mixed density lesion over the third ventricle causing hydrocephalus. So the size is about 8 times 6 cm, 8 times 6 times 6 cm, and then we proceed with MRI for this patient. Noted there's a mixed density lesion, most of solid component, with evidence of hydrocephalus. The size is about 6 times 6 times 8 cm. So we subjected this patient for embolization before we proceed with surgery. 3 days after that, we go with surgery, but because this patient has while waiting for the surgery, we noticed that patient become drowsy, so we subjected her with a left frontal EVD for her hydrocephalus. In looking at the scan, this is post left frontal EVD pre-tumor excision. We noticed that it's best to come from the left frontal region, left frontal horn, because the tumor is located closer to the left frontal horn. So our plan is to go from the left frontal horn, and then, but as mentioned before, we will insert another EVD on the right frontal horn. so that it can assist us in giving temporarily CSF drainage for this patient. So intraoperatively, this is the position for this patient where you can see there is a left frontal EVD, and we do and you can see there is incision at the bicornal region. So post-surgery, this is post-surgery. The surgery actually is not really eventful like the previous one, but post-surgery, we notice that post-op CT scan, the patient has a significant tumoral bleed, blood clot at the tumor bed. So because of that, we didn't extubate this patient. We nursed this patient in our ICU, same like the patient before, and then we keep a close observation for this patient. So on a post-op day 2, actually her condition improved to M5, but unfortunately we noticed that she started to have hydrocephalus. So because of this, we plan, and at that time also we assessed her clinically, and the pupil that we noted that she had pupillary changes. With pupil is a 2-3 with 2 over the right side and 3 over the left side. So in this condition, we believe that the clot causing obstructive hydrocephalus. Therefore, we inserted a left parietal occipital EVD for this patient. So meaning that this patient currently has 2 EVD. So because we believe that a long insertion of EVD for a patient can cause infection, so we change the EVD. We remove the EVD on the, actually currently patient on both EVD, but the EVD of the left parietal occipital, we remove it to Omaya, and we do a tapping for this patient daily and based on her clinical symptoms. So if I'm not mistaken, we did tapping for her Omaya daily for almost 5 days. So after that, when we noticed that her CSF is less zentochromic compared to before, then we did another scan, and at last we removed bilateral EVD. So on the right side, we removed bilateral EVD, and then we inserted shunt for this patient, right parietal occipital and also left parietal occipital shunt. Okay, this is the image showed that the blood clot is clearing up, and the patient's condition is actually already walking, but she is still not walking, ambulating using wheelchair. But we remove the Omaya or the left parietal occipital, and then we change to the permanent VP shunt, left parietal occipital VP shunt, and she is now on the bilateral shunt. The HPE result came back as central neurocytoma grade 2 with residual tumor is about 1.5 times 27 cm. She just completed chemotherapy in February 2023. We follow up this patient for almost 2 years, and she is currently able to work back at her previous center, and she successfully climbed the highest mountain in Malaysia. This is the this is the post-MRI for this patient post-surgery. We noticed that the tumor is about 1.5 times 2 centimeters. I end my presentation here. I would like to have some opinions from the expertise here. Thank you.
Thank you very much. Very nice cases, Dr. Asma Afifi. Probably before that, probably Professor Kato, you have any opinion, or Professor Ohata?
Yes, maybe the Ohata and the Professor Goel, the 2 giants, is with us now. Can you ask Ohata Sensei and Goel Sensei,
so first
please?
I will comment. So first case is very, of course, complicated. Before the operation, I want to know the information regarding the vascular structures. Feeder is usually come from the choroidal artery, anterior choroidal artery, or medial or lateral choroidal artery. So we must check the location of the feeders. And the approach should be selected based on the feeder. In the early stage of operation, we must coagulate the feeder first. Or if there's multiple feeders, the wide exposure is, of course, important. So anyway, before the operation, we know the location of the feeders, and also when we perform the corticectomy, we know the anatomy of the cortical venous structures. This is my comment. If once feeder is coagulated, dissection of the tumor is not so difficult. And I missed how to access to the second case. I missed that. This is my comment. So of course, second case is located in the midline in the brain. So maybe I will select the transcausal approach. This is my comment.
Thank you very much, Professor Ohata. Dr. Asma, do you have any?
Yeah, can I comment a small
Okay,
comment?
yes, Professor Arthur.
Yeah, this I didn't see the first case. I saw the second case. Unfortunately, I didn't hear what the histology of the tumor was. I expect that this was a central neurocytoma. Is that right, Asma? What was the histology of the tumor?
I'm sorry, your voice is fading, Professor Arthur. Go.
Can you hear me now?
Okay,
Yes,
okay.
now it's clear.
So I am wondering what the histology of the tumor was. I think this might be because it is located in the intraventricular region, in the lateral horn, in the midline, such large tumor. My feeling is it was a central neurocytoma. Is that correct, Asma? What was the histology of the
Central neurocytoma grade 2, just completed radiotherapy also.
So this was a central neurocytoma. Central neurocytomas are difficult tumors, but if you are able to resect these tumors radically and quite radically, you may avoid radiation treatment and the person can be cured. Means there is no radiation required. Even if you leave a small amount of tumor, radiation may not be required. However, as you have noticed, that surgery is difficult and sometimes quite difficult. I will not resort to preoperative embolization in these cases. These are vascular tumors, but they are having not a very specified feeding vessel, and embolization is usually not necessary. They are relatively soft tumors, they are quite vascular tumors, and radical resection has to be done. What I do is, as Professor Ohata said, I adopt transcallosal approach on the side of larger tumor, and then we have to learn the art of breaking the tumor, break the tumor amidst bleeding vessel. We have to we have to remain intraventricular. We cannot go outside the ventricle, particularly in the region of foramen or Monro. If we go outside, we may create a very bad hemiparesis or hemiplegia. So remain inside the ventricle, go on debulking the tumor, go on debulking the tumor. As you have seen, it is not only in the lateral, it is going in the occipital horn, it is going in the frontal horn. It is quite a large tumor. However, these large tumors have to be resected radically, and that is the trick. If you resect, you cure the person. And you have treated the patient very well. I usually don't resort to so many EVDs that you have put. I don't usually like this kind of maneuvering. I like to do quite a, but it is fortunately for you, this patient has come out well and she is doing well. And, my best wishes to you, Asma.
Thank you so much.
Professor Atu, if don't using the AVD, what do you like to diverse the CSF from the?
See, if at all I have to do, if the ventricle is large and causing problem, I like to do just tapping and leave it. But it is also very rarely required. If you are able to remove it properly and completely, there may not be need for any kind of ventricular drainage or any kind of but of course these tumors are dangerous and these tumors can be vascular. So either you give good, beautiful new life, or you can demolish the person quite badly. So here and there. And what matters is good tumor resection. And if it, I must say that ventricular drainage is extremely rare in my story. Very rarely I do. And recently I published my series on lateral intraventricular tumors. Most of them were central neurocytomas. And I think the series, I don't know the exact numbers, but Dr. Abida may know, which was the largest published series on intraventricular tumors of this kind, exactly of this kind. And I don't think too many times ventricular drainage was done in the entire series. Dr. Abida, if she's there, she can update the series. Abida, are you there?
Yes, sir. Yes, sir, I'm here. I think it was 104. I'll just check, sir. Give me a minute. And we have hardly used ventricular drainage. Most of our tumors were central neurocytoma. And I think it was an experience of 145 cases, which was the largest experience in the world.
Yeah, thank you. What do you think if do you think is it matter if is it usual if we do the biopsy per endoscopic biopsy before we decide the surgery to know what is the substrate, what is the pathology of the tumor, and then we decide how to do the treatment of for the removal or another anything else. What do you think about that?
This is a very important question. Most of the intraventricular tumors, most of them, even if it is a meningioma, if it is a central neurocytoma, even if it is an ependymoma, most of them are low-grade tumors. Most of them are very large in size because ventricle keeps on accommodating and it becomes large before diagnosis. So large in size, vascular in nature, more benign in their condition, and majority of these tumors, like even ependymomas, intraventricular ependymomas, are usually low-grade tumors. Meningiomas, of course, low-grade. Neurocytomas are low-grade. So most of these tumors in the ventricle are low-grade. They are vascular. They are large. And there is no need for biopsy. Most of the times you may be able to identify what is the nature of the tumor on good imaging. There is no need for biopsy as a special operation.
Okay, thank you. Is there any other opinion or comments from discussion? Maybe Dr. Fahmi or Dr. Mabadalayev or maybe Professor Ohata again.
Yes, my opinion is same as Professor Goel. No need to perform the biopsy.
Okay. Is there any other question from the floor? We have here the question from Surya Pratama. Thank you very much, doctor. My name is Surya, neurosurgery resident from Airlangga University, Surabaya. In a large intraventricular tumor with ventriculomegaly located on left lateral ventricle, what approach do you prefer between anterior transcortical or anterior transcallosal? Professor Ohata, probably you want to answer to this question. You're still muted, Professor. Please unmute.
Yeah, I'm sorry.
Okay.
Would you I missed your question.
Okay. He is asking about enlarged ventricular tumor with ventriculomegaly located in left lateral ventricle. What do you prefer to choose for the approach? Is it anterior transcortical or anterior transcallosal?
High parietal approach or transtemporal approach. And transtemporal is low as possible. I like to use inferior transcervical approach. And patient, post-operatively, patient never develops aphasia and visual field defect. Also, high parietal approach is good. And so, depending on the location, I select one of each.
Okay, thank you. Probably, Professor Goel, do you have any opinion?
Yes. My opinion is, when the tumor is in the lateral ventricle, I like to do transcallosal approach. And never I like to do transcortical approach. That is one. But I modify the transcallosal approach a little bit when I do interhemispheric exposure. I go into the corpus callosum and cingulum little laterally and take a cortical incision in the cingulum and in the corpus callosum lateral to the anterior cerebral artery complex. So it is a modified transcallosal approach. And once I open the tumor and once I get the CSF in the ventricle and once I debulk the tumor, the whole story becomes lax and the exposure can be widened. So this is my approach for all, irrespective of, unless the tumor is going too much in the temporal horn, too much in the occipital horn, or in other location, then my approach may differ. But in general, my exposure is interhemispheric, transcallosal, modified a little bit here and there.
Okay, thank you, Professor Goel. We have here raising hand, Dr. Professor Farhad Ahmed. Please ask your question.
Yes, thank you for giving me opportunity to ask question. Thank you, very nice to hear from Professor Atul Goel sir, and also from the dignities of different countries. My question is, the lateral ventricle, sir also already mentioned, like to approach from the interhemispheric approach, if it's located in the laterally. If sir, if we could use any gravity retraction or a vertex of the head parallel to the floor, or a bit gravity retraction helps to reach there. This is my first question.
To answer that question, you know, what we have to do in these cases, we have to keep the head very high. Very high. The flexion of the neck and flexion of the head has to be high so that we operate from above. And we have to go ipsilateral. The larger side tumor, we have to approach from that side. You know, and if it is located in the lateral ventricle, there is no need to do any gravity assistance or anything. It has to be midline approach, interhemispheric approach, make cortical incision, make a, you know, selected callosal incision. Callosal incision also has to be in front of the coronal suture. That is very, sometimes, you know, you go behind the coronal suture and interhemispheric connections of corpus callosum can become into a little danger position. So as far as possible, take the callosal incision anterior to the coronal suture, and then you can widen it transversely or even anteroposteriorly. As soon as you enter the ventricle, sudden gush of CSF will come from the area and the whole thing will relax. So until you reach the ventricle, the brain is tight. But as soon as you reach the ventricle, everything becomes stabilized. The most important issue in these tumors is they are vascular tumors and they might bleed quite furiously during operation. So what we have to do is rather hurried operation. If we go slowly, coagulating at each step, we may not be able to complete the operation because it bleeds. So we aggressively enter into the tumor and debulk it quite. Many of these tumors are soft. Most of the intraventricular tumors like neurocytomas and ependymomas are soft in nature. Meningiomas are little firm in nature. So meningiomas you have to get, as Dr. Ohata said, get to the choroidal feeders early in the operation. Debulk the tumor, get to the choroidal vessels, take the vessels, and then continue debulking. So this is I don't like gravity assistance to answer your question in large tumors like this. In small tumors where we are going to the thalamus and traversing to the third ventricle and things like that, subchoroidal approach and all those kinds of transvelum interpositum approach to the third ventricle, thalamic tumors, maybe gravity assistance is required for smaller tumors.
Thank you, sir. Thank you, sir. A bit last question to the speaker. What protocol of anticonvulsant or anti-seizure drug do you use or do you follow? Thank you.
For this patient, actually we didn't start any. What drugs do you mention just
My
now?
question was anticonvulsant drugs. What are the perioperative anti-seizure drug you use?
Oh, we don't have any anti-seizures drug for this patient. Patient don't develop any seizures, and we don't start any anti-epileptic drugs.
Okay.
Okay, I think benefit of time, we are running short. Maybe we can move on to the third speaker. Myrna, are you ready to introduce our third speaker?
Yes. Thank you very much, Sharon. The third speaker, Professor Kenji Ohata, the honorary professor from Neurosurgery, Osaka Metropolitan University, specially appointed professor, Department Minimally Invasive Neurosurgery in Osaka Metropolitan, Osaka, special advisor, Social Medical Corporation of Kodokai. Please, Professor Ohata.
Okay, thank you for inviting me to this conference. My topic is surgical anatomy of the cavernous sinus. So this is from the publication of my mentor, Professor Akuba. It's just a moment. 30 years ago. So cavernous sinus has 5 surfaces. One is a superior surface, lateral surface, medial surface, inferior surface, and posterior surface. So we must understand this anatomy. And of course, there is a many cranial nerve along the lateral wall of the cavernous sinus. So I want to mention the anatomy of cavernous sinus, focusing on the surgery. There is a many regions arise from this part, tumor, aneurysm, and others. And aneurysm is nowadays treated by the endovascular approach. So we should focus on the tumor surgery. And meningioma is actually arise from the wall of the cavernous sinus. So I want to focus on the surgery of the meningioma to describe the anatomy of the cavernous sinus. So this subject is to describe the anatomy of the cavernous sinus, focusing on how to remove the tumor from the inside of the cavernous sinus with functional preservation. So firstly, in the treatment of the cavernous sinus meningioma, small tumor nowadays mainly treated by radiosurgery. And there is some difficulty in case of the recurrent after radiosurgery or in case with a symptomatic non-small tumor. So in regarding the secondary cavernous sinus meningioma, this is a sphenoid meningioma extending to the cavernous sinus. This is a pediculabar meningioma extending to the cavernous sinus through the posterior wall. We remove the tumor outside of the cavernous sinus like this, and tumor left behind inside the cavernous sinus. If it grow, it acts as a real primary cavernous sinus meningioma. So we must know how to remove the tumor inside of the cavernous sinus. So this is there is 3 possible access route to the cavernous sinus. One is anterolateral approach using pterional approach or orbital-zygomatic approach. Second one is transsphenoidal approach, and the third one is transpetrosal approach. I will focus on the third approach. So first approach, of course, it's a common approach to the sphenoid meningioma extending to the cavernous sinus. We use pterional or orbital-zygomatic approach, of course, but in this case, of course, we should keep outside the cavernous sinus. We leave the small piece inside the cavernous sinus. This is maybe it's a standard procedure for you as well. Sorry. And access to the transsphenoidal approach is nowadays getting so common using endoscope. This is a relatively wide space wall to access to the inside cavernous sinus. But there is a carotid artery. It's very dangerous, of course. So we developed the posterior crinoidectomy approach to open the cavernous sinus. This is a publication from our department in 2019. By a transsphenoidal approach, we remove the posterior crinoid process. Sorry. And then we enter to the cavernous sinus. Sometimes we relocate the pituitary gland and we can enter to the cavernous sinus. This is such case. This is a primary cavernous sinus meningioma. Patient visit with development of the diplopia. we perform the transcolloidal process approach, and we remove the main part of the tumor. Of course, some part left behind inside the cavernous sinus. This is, of course, limitation of the meningioma surgery, regardless any types of the approach. So third approach is Petros approach. I want to focus on this approach. This is a very good approach. You must know this approach. So this is a very reasonable approach to the surgery of the petroclavicular meningioma extending to the cavernous sinus. This is a relatively wide space. This is, I call the back door. There's no door in the frontal side. Lateral side, very so tight. There's no space. And of course, superior door, superior wall, there's a Hakuba triangle. This is actually not a good approach. I recommend to use the transpetros approach to enter to the cavernous sinus. This is a schematic drawing on the transpetros approach. On the left side, this is for your operation orientation. This is a trigeminal nerve. This is a 𝑐𝒉𝒂𝒃 nerve, 7th and 8th nerve, lower cranial nerve, abducens nerve, and the tracheal nerve there. This is the tumor. During the operation, we debulk the tumor, identify the tracheal nerve. In my case, I preserve all cranial nerve. I try to preserve even tracheal nerve should be preserved, and the 7th, 8th nerve confirmed, and abducens nerve confirmed, and then we follow this cranial nerve to anteriorly, and then we complete the surgery. Of course, we started this approach for the last 50 years, half century, we're doing this kind of approach. We report the 9 cases which operated between 2014 and 2018. We summarize 9 cases, 2 female, 7 female, and 5 cases. Half case has a previous operation and radiation. There's a recurrent tumor. This is very complicated. So patient referred to our institute. First case is a 44-year-old female. This is a real cavernous sinus meningioma. Patient develops the oculomotor nerve palsy. What we should do this kind of patient? Should we send the patient to the gamma center, or we should operate? My selection is operation, because this is a very 44 female, very young in Japan, even in the India, very young nowadays. So very young patient, I don't like to perform the gamma knife. Operation is very safe. Believe me, it's very safe. Wound recovers after 3 months. It's good enough to recover the wound. Healing is so we have such kind of capability. Our approach is transpetros approach. This is a trigeminal nerve here, and tumor is growing, or attachment, origin of the tumor is posterior wall of the cavernous sinus. This is a tracheal nerve. This is for your operation. Tracheal nerve, I don't like to cut any part of the cranial nerve. This is a Meckel cave is opened. We go forward, and then we remove the tumor from the posterior wall of the cavernous sinus. We go further forward, and the next target is oculomotor nerve. This is the oculomotor nerve here. This is oculomotor nerve. You can see this is a cranial nerve, and then this is a normal anatomy guided operation. Once we confirm the normal anatomy, we dissect along these cranial nerves, tracheal nerve, oculomotor nerve. This is a very small, tiny cranial nerve, but this is very important. Of course, there is some limitation. We cannot enter to the inside anterior part of the cavernous sinus. Previously, we performed the exposure, C1, C2 exposure in this operation. Of course, we must damage the cranial nerves. So this is the final part of the operation. This is so outcome of the surgery. This is a post-operative image. This is a concept of the surgery of the meningioma is to earn the time. So life is limited. 80 years or 100 years is a limitation of the life. We should earn the time for the patient. This is a tumor left behind in the anterior cavity of the cavernous sinus, and we wait and scan. And this is outcome. So cranial palsy is improves. No oculomotor palsy after the operation. So this is a second case. Patient has a left frontotemporal approach activated 4 years before, and the gamma knife, and the tumor continued to grow. This is the MRI before the surgery in my department. This is very deformed tumor, and the space is transpetral approach. We must develop the tumor as much as possible. So this is operation same as in the first case. This is a left-sided transpetral approach. This is a trigeminal. This is a very, very stereotype. If you run this approach in the cadaver dissection, you can use this approach in the real operation. So this is a visual artery, in same as ventricular spinal ridge meningioma. If we remove the tumor resection creates a space to go to the deep part of the tumor. This is a trigeminal nerve. Now we must pay attention to avoid injury of the carotid artery, and of course we use Doppler, and we can carefully dissect the posterior wall of the cavernous sinus. This is a third nerve here. This is a left-sided, so this is third nerve here, trigeminal nerve here, cavernous sinus. Now we dissect in the cavernous side. This is a internal carotid artery. This is we had a nightmare 30 years ago or 40 years ago. We pull the meningohypophyseal artery and we injure the internal carotid artery. We had a bad experience. Afterward, of course, we know how to stop the operation, where to stop, how to stop the operation. You must understand this complicated operation. This is outcome. So some small piece left behind in the anterior part of the cavernous sinus. This is the last case, 38, very young female, and huge pedicular meningioma. Maybe origin is cavernous sinus. This is facial numbness and hemiparesis. So no, of course, no gamma knife also, of course. This is our strategy is combined transpetral approach to remove the major part of the tumor, and then followed by endoscope nasal approach if requires. This is if you carefully observe this MRI, there's a ligament. There's a ligament. This is a normal anatomy guided operation. This is a normal anatomy and anterior petrocranial and posterior petrocranial and intercranial ligament. And third nerve is protected by this ligament. So you must follow this ligament. So transpetral approach, same as in the previous case. This is a left-sided. Left-sided. This is the inferior caudal part, cranial part, trigeminal, as in the previous cases. Trigeminal and petrocranial ligament here. Second nerve here, third nerve here. Even in the large tumor, what we doing the same. Normal anatomy guided operation. This is a fourth nerve. Even in this case, we preserve the fourth nerve. Once we cut the fourth nerve, there is no guide. We lost the orientation. All cranial should be preserved. This is normal anatomy guide us to the appropriate orientation. This is a final stage of the operation. Because there is a size of the tumor, we can remove like this. So finally, this is a MRI after the first operation. Some part left behind in the center of the cavernous sinus and the medial part of the cavernous sinus. Next, again the operation. Of course, this is a transparent approach, very safe as far as we know the location of the internal carotid artery. This is the midline approach. This is the endoscopic, endonasal, and transposterior cranial process approach. This is a posterior cranial process. We can remove, after removing the tumor, we can enter to the inside of the cavernous sinus. Now we can enter to the medial cavity of the cavernous sinus. This is actually very boring regarding the video because area is the same. This is a third nerve. Now, of course, goal of the operation is not total resection. This is very dangerous. We must stop the operation. And this is outcome. This is before operation, after first operation, after the second operation. Patient is 38 years old. We can, at the time, of course, if that one tumor grow, maybe we second choice maybe is gamma knife radiation according to the pattern of the operation, the growth. This is ocular nerve. All function is preserved. Believe me, this is we report this case in Journal of Neurosurgery 4 years back. This is the first case before the operation, before post-operation, before and post-operation, before operation, post-operation, pre-operation, post-operation, before post-operation. So this is a summary of the cases. We operate 9 cases, post-operative radiation. Some case, yes, we pump the radiation. And KPS performance status is improved post-operation. So as far as you dissect along the normal anatomy, you can preserve the cranial nerve function. Some are malignant one. Of course, we perform the gamma knife. This is a 3.15. We perform the radiation treatment. This is a conclusion. Back door, I call this back door, and inferior door can provide the maximum exposure cavernous sinus with good functional outcome. This is my message. Thank you for your inviting me to the conference.
Thank you very much, Professor Ohata. It's very complicated but interesting and wonderful.
Sorry, so
wonderful
complicated.
result.
So
Yeah.
complicated. This is I want to show the concept of the skull-based surgeon. Meningioma is very complicated. Nowadays in Japan, people live 100 years. We perform the gamma knife 40 years old. At age 40 years old, I'm dying. I'm dying. So I remove the tumor as much as possible. Surgery is very safe, believe me. But of course, you know the anatomy. Thank you for your attention.
Yeah, excellent surgery, Professor Ohata. Please, Dr. Ahmad Fahmi, you want to ask question, please.
Thank you very much, Dr. Mina. Thank you, Professor Ohata. Thank you very much. I looked at you. Is there always use transpetrosal approach, yeah, bro? How about another approach like subtemporal? Is there any advantage and disadvantage of this approach? Thank you, bro.
Yeah, transpetrosal approach is extension of the subtemporal approach. So, but there's a petrous ridge there. So this is we must remove the mountain to access to the main part of the tumor. So transpetrosal approach not so complicated. We currently call this mini combined transpetrosal approach. So this is this concept is same as subtemporal approach. So, but there is a vein of Rabe there. In the transpetrosal approach is epidural approach. Vein of Rabe on our other venous structures is protected by the dura mater. This is a concept is epidural approach. Epidural because very many important venous structures. Thank you for your question.
Excellent, Professor.
Thank you, Prof.
Yeah. Thank you for the question, Dr. Fahmi. And Professor Atul Goel, please, you had open your mic. Maybe you have opinion.
Yeah, cavernous sinus meningiomas are difficult problems. There are various issues in cavernous sinus meningioma. One is when to operate. Second is how much to operate. Third is how to operate. So it is a complex issue. Means first is you know how to operate, because the potential of complications, potential of third nerve weakness, potential of sixth nerve weakness, potential of carotid artery injury, problem of V1, the trigeminal sensory loss. There are so many potential issues in cavernous sinus surgery that you should be very much conversant with the anatomy, as Professor Ohata has said. You must be master of anatomy, normal anatomy, and in tumor, the anatomy becomes abnormal. So you should be able to identify how the nerve enters the cavernous sinus, how it exists, and you have to save it. You see, if you remove 80% of tumor and if you remove 30% of tumor, it may not be of much difference in the long-term outcome. But if you create third nerve palsy, if you create carotid artery injury, you can create a devastating complication. So my philosophy over the last 35 years with cavernous sinus tumors, particularly meningioma, has changed. My policy is that you have to be very, very safe in cavernous sinus meningioma surgery. You have to be radical but safe. Most important is if your surgery is going to lead to third nerve palsy, if your surgery is going to lead to V1 division injury of trigeminal nerve, if your surgery is going to lead to sixth nerve injury, it is a complication of surgery and it should not happen. It can happen, but it should not happen. So cavernous sinus surgery is the very, advanced form of neurosurgery. We have to learn the technique of breaking the tumor, technique of hemostasis, technique of working within the planes that the tumor will give you, learning how to dissect and isolate the nerves. It is not easy. What Professor Ohata is showing is the ultimate, the top-end surgery in cavernous sinus surgery. And one may not be, as I have told you, I have myself changed over the years, and my radicality of my surgery has now diminished as far as cavernous sinus meningiomas are concerned. And my safety of the cranial nerves has certainly, without any doubt, increased. So I am a little bit, I don't like radiation treatment, I must tell you. I don't like to give radiation treatment. I don't like to be too aggressive in cavernous sinus tumors. But if the patient comes to you with a third nerve palsy, there is only one thing which can improve the third nerve is by doing a safe resection and isolating the third nerve and protecting the third nerve. So the indications of cavernous sinus surgery are here and there, and we have to be absolute master of neurosurgery. We have to be philosophical, we have to be technical, we have to be anatomical, and we have to be really good in our understanding of surgery. And we have to do surgery not to show our clinical results, our radiological outcome, but for the patient. The patient has to, reasonably come out of surgery with reasonably improved problems. If you create deficit, it is not a good operation. If you create disaster, it is a dangerous operation. And all these things are possible in cavernous sinus surgery. So we have to be very, very master of everything if we have to go. How to retract the brain, how to open the dura, how to dissect the nerve, how to isolate the carotid, how to isolate the sixth nerve, how to work, which direction to go. The direction of petrosal approach, which Dr. Ohata mentioned, is a beautiful approach. You know why? Because we are going inferior to the cavernous sinus. The V1 division is away from the surgical site. If we come from pterional approach, the V1 division will be quite in close to the surgical exposure. If we come subtemporal, that is a good approach. Subtemporal, extradural approach, intradural. So there are various things in cavernous sinus surgery, and I am sure what Dr. Ohata has said is the ultimate end of the surgery. But we have to know for our own patient what the patient needs and how we have to operate on these patients.
Maybe Dr. Mizuho, you have some comment? You're skull-based neurosurgeon. Please, Goel, please take care of her, please.
A very instructive lecture. The idea to to preserve the fourth nerve as a guide is a very good idea, but you actually did not cause any fourth nerve palsy when you operating around the fourth nerve and any other cranial nerves. What is the tips to dissect the cranial nerves without damaging new, causing new damage?
Yes, thank you for a good question. This is cranial nerve. Typical anatomy of the cranial nerve is trigeminal nerve. Trigeminal nerve has a cistern, cistern, Meckel cave. Each cranial nerve has such kind of Meckel cave: oculomotor cistern, trigeminal cistern, and trochlear nerve cistern. We must dissect along the cistern. So as far as we dissect the lateral side of the cranial nerve, we never enter to the cavernous sinus. No risk of the injury of the carotid artery. We keep outside lateral to the cranial nerve. This is a key technique to preserve the cranial nerve. And the trochlear nerve is very tiny, but it's a motor nerve. As far if the anatomically preserved, its function recovered. Believe me.
Thank you.
Okay, is there any question? Any other question? Okay, if there's, Dr. Dishold, Mama Delegate, please.
Thank you so much for beautiful presentation, Ohata Sensei. My question is, when a patient developed already for example, oculomotor palsy or trochlear nerve palsy, and you do a surgery and you dissect the nerve safely, you decompress it, you remove the tumor, what is the chances of total rehabilitation of the nerve? Does the nerve rehabilitate totally, or it depends on the duration of the palsy, the time of the development of the palsy?
So your question is when cranial nerve function recovers, right?
Yes, yes.
Just we must wait, wait and wait. Usually 3 months or 6 months. In some case, one year. And this is if you stay in the posterior cavity of the cavernous sinus, the risk of the injury to the cranial nerve is very low. But you enter to the anterior cavity, structure is very complicated. Trochlear nerve cross over the oculomotor nerve, and there's first segment of the trigeminal nerve is spread. Very dangerous. Please stay in the posterior cavity of the cavernous sinus. This is my message. And wait and wait. And it recovers, believe me. Try it. And if you have such case, please call me. I will visit your institute.
Just I want to ask, because almost the same question of the deal shot. So what's the cause of the palsy? That is just compression or invasion, or I don't know the details.
Yeah, in case of yeah. Thank you for your question. It is usually compression. As far as there is a dural fold, and by the compression of the tumor to the cranial nerve, it's kinked. Dural fringe kinks the cranial nerve, and debulking means just debulk, and we should cut the oculomotor. There's a ligament, and decompression carried out. It's like the optic nerve decompression. We cut the optic, we unlock the cranial optic canal, and we cut the dural fold, and then optic nerve decompression is completed. Its concept is the same. If the tumor is benign, decompression is possible. If the malignant, of course, it embeds the cranial nerve, embeds the carotid nerve, so surgery is very complicated, of course.
So one more question is, maybe a longer compression time, longer duration, the compression of the nerve, so the nerve become weakened. Is it right? Just I want to ask. Because that is a big difference from a vascular lesion and also the tumor lesion, because once the nerve became the weakened, so it's quite difficult to recover completely. It take a longer time. What is opinion? Oh, Sensei,
What
go ahead,
we
Sensei.
can, of course, it's there are so many cases, of course, and what we can do is just a resection of the tumor. That's
You
my
know what?
I'm sorry.
That is a very important. That is a very important question.
Thanks.
You see, even in suprasellar meningioma, if your visual deficit is for 5 years and 6 years, the tumor is firm and tumor is difficult to dissect from the optic nerve. If the visual deficit is for 2 months or 3 months, the dissection of the nerve and the recovery of the nerve is much better. So in my understanding, that one is the degree of cranial nerve deficit, degree of visual deficit in suprasellar meningiomas, for instance. If the patient is blind, the attachment, the dissection is more difficult. If the patient has severe deficit in vision, the dissection is difficult. If it has partial deficit, the dissection is easier. On the other hand, if the duration of the deficit is for 5 years, 6 years, the dissection becomes difficult, the nerves become stretched and filmy, thin. And also in this situation, the tumor is firm and tumor is more benign. So if there is a long duration, 5 to 6 years duration of visual deficit, the tumor is firm and less aggressive. If the duration is short, the tumor is soft. So duration of visual deficit and the extent of visual deficit, the extent of cranial deficit is very important to decide how much difficult the dissection will be during operation.
Okay. Great suggestion. Thank you very much.
I made one classification, Yoko, of tuberculum celli meningiomas.
Okay.
Long time ago, about 10 or 15 years ago, where
Okay.
I made this point of degree of deficit and duration of deficit. And both of these parameters were included in my classification of difficulties in operation.
So that's a very important point, I think. Thanks. Excellent. Sharon?
Thank you. I'd like to thank all our speakers, Prof. Ohata, Dr. Inui, and Dr. Afifi, for your presentation today. I think it was very enlightening, and I think we had very good discussion with Professor Atul Gol coming in and giving it a bit of more spark in it and making it more interesting. I thank our discussants, Mama Delif and also Fahmi, and also like to thank our chair for today, Professor Mirna Sobana, for taking her time to chair this webinar. I think we'd like to see Prof. Kato. Would you like to say anything before we call?
No, today is Avida Shah did not say anything, so please, Avida, you are very silent today.
No, Professor Kato. I was just listening, enjoying the webinar. When my boss speaks, I cannot speak.
I was just about to say that a boss is here today, Prof. Kato, so that.
But I think, how to think, because the more female doctors can attack the skull-based lesion, it's very good, tendency, I think.
Yes, it's a very good field, and people who are interested should definitely pursue it, because it is core neurosurgery, and the whole key of that neurosurgery is anatomy. So it is a very good field to pursue.
Thanks so much. So maybe finally, I think Ohata Sensei and Gol Sensei, please encourage the female skull-based neurosurgeon. It's increasing in Japan also, please.
Yeah. So I'm so happy to have a time with you in this conference. Thank you for inviting me, Professor Kato, and Dr. Inoue. Best regard to Kimpyo Sensei. And I'm very happy. So anyways, minimally invasive procedure is so good. Sometimes it's very dangerous, of course. and you can stage the surgery. In huge tumor, you can stage the operation, and the first operation after the 1 month after the operation, you can remove the tumor totally. So this is very good for your family, for a partner as well. So it is a many strategy to complete to be the master of the neurosurgeon. So I'm happy with lady neurosurgeon tonight. Thank you very much.
Sensei?
Yeah, I'm sure the future of fine microneurosurgery will be women neurosurgery, because the future is, if some of you know that my daughter is also becoming a neurosurgeon. She's a 4th year neurosurgery resident, and she always say, Daddy, you don't know this, you don't know that. Only one person who can argue with me in this world is my daughter. And I have a feeling that she will become a good neurosurgeon, like most of the girls on the screen. And I wish when I can wish my daughter the best, I can wish all my female colleagues the best. And I hope it is a difficult subject. Neurosurgery in general is difficult. Neurosurgery is time consuming. Neurosurgery takes a lot of efforts. I wish all of you can, because ladies' fingers are the best. You have to learn how to control bleeding. You have to learn how to dissect. You have to be good in it. You have to be aggressive and strong in it. You have to be mentally strong in doing all these things. So it is, I know for girls, it is maybe time is a little bit factor, but you get over this and you will surely and definitely the future will be in skull-based surgery. I'm not sure if Ohata agrees, but women will soon and definitely take over in this field of skull-based.
Thank you very much. Already, Dr. Goyle, you created such a wonderful beta chart. That is your great teacher. So we look forward to maybe to work together with your daughters in the future. Thank you very much for both of your great comments. Thank you very much. So, Sharon?
Yeah, so I think there was a very interesting feedback from both our senior neurosurgeons here today. So I think all the women here, I think that is something for you all to take home. And I think it's a good thing, for you all to pursue further. So good night and thank you, everybody. And